Welcome to the Lighthouse Podcast, a resource created by Lighthouse Family Retreat to strengthen families living through childhood cancer. You'll hear stories from families, educational information on childhood cancer, and most importantly, we will be there to encourage your family during your journey. I'm Christy Richards. I'm sitting here with Chris Woodruff, and we are in the middle of Childhood Cancer Awareness Month. If you want to track along with what we are doing this month to raise awareness and support, you can follow us on Facebook and Instagram at Lighthouse FR.
That's right. It's been a pretty great month so far. We've been highlighting and sharing about families each day just to try to raise awareness. Today we're sitting with James Ludeman. James is sharing his knowledge as a pediatric oncology nurse. He works here locally in Atlanta at the local children's hospital. And he's going to help us understand some more about childhood cancer, some of the common types and terms that you might want to learn and know. And so if you're new to this journey, or if you're supporting someone, this is really especially important if you're just new to the world of childhood cancer and wanting to learn so you can better support someone. James, welcome to the Lighthouse Podcast. We are super excited to have you. We're talking about today childhood cancer and really trying to get some understanding of childhood cancer. And so wanted to start with, just for folks to really have a baseline, can you spend a few minutes and just explain what is cancer?
Yeah, absolutely. Hey, I'm so excited to be here. Thanks for having me, guys. So I think the number one thing that people always think is, is cancer this one disease, right? And what we all know is that cancer is not one disease. It's this group of diseases that there is that it's characterized, or all of them involve uncontrolled growth of cells and potentially uncontrolled spread of cells throughout the body. And so I usually start with the new family, making sure they understand that, childhood cancer is pretty rare in the scheme of things compared to adult cancer. Is very different based on what type their child has, and then make sure they understand what cells are and they're these building blocks of the body that they just can get out of whack and grow out of control sometimes.
So James, you've already mentioned that, it's different. Kids get different kinds of cancer than adults do, which I did not realize previously. So we've kind of started out by just putting in four main categories of cancers in children. And I'm going to start with the one that I'm most familiar with, that my family went through, which is the leukemia category. So can you talk through a little bit about just kind of what the characteristics are? I know there's many subtypes of leukemia in children, but just kind of what it's known for, what the characteristics are.
Yeah, absolutely. So like you said, Christy, childhood cancer is very different than adult cancers. Most childhood cancers are not strongly related to environmental factors or, lifestyle factors like adult cancers often are. But yeah, the leukemias. So leukemias, there's several types of leukemias in childhood cancer as well, but they make up about 28%. This is the nerd in me that my wife would make fun of a little bit, but yeah, about 28% of childhood cancers are leukemias. And the main ones you think about in childhood are the acute leukemias, right? So you've got ALL and AML, and we won't spend much time getting into the weeds with that, but ALL is the most common childhood leukemia, most common childhood cancer. And then a couple of kids and teens could be diagnosed with a cancer called CML, which is a more chronic condition.
Okay, so that's that. We were the ALL category, which, like you said, is the most common type. And in that world, I think everybody knows just about the cancer that they have. They haven't had time probably to research others. So talk to us about lymphomas. That's a completely separate category.
Yeah, absolutely. And actually, once you started talking, I realized I didn't even really describe what leukemia was. But leukemia is, cancer of the blood, right? So white blood cells growing out of control. But yes, lymphoma. So lymphomas make up only about 8% of childhood cancer. And so lymphomas are uncontrolled growth of cells in the lymphatic system in the body. And so these are tissues like the lymph nodes, the thymus gland, your adenoids and tonsils. And so they can be closely related to leukemias in that a lot of times it is lymphocytes, a type of white blood cell, that are out of control in lymphomas. But whereas leukemias start in the bone marrow, which is where your blood cells are made, lymphomas start in the lymph tissues, like I said, lymph nodes, tonsils, adenoids, thymus. So less common than childhood leukemia, but still very common, especially in the teenage years. There's a large spike in lymphomas in that time of life.
Interesting.
Yeah, and I should mention that when we say pediatric or children's cancer, we're also including teenagers in that. What age range, I actually don't know the answer to this. What is the age range where it's still considered, is it 20, I mean, is it a 21-year-old thing? Is it an 18-year-old thing when we're talking about pediatric cancer?
Yeah, good question. I think people have, obviously, across the country have different definitions of this, but what I like to pull from a lot of times is places with statistics and figures. And so, again, adjusting my nerd glasses, the American Cancer Society has like annual reports and things. And so they typically break the statistics up into ages 0 or birth up to 14, and that's considered childhood cancer. And then ages 15 to 39 is adolescent young adult, but then they do a little breakdown for 15 to 19. So I'll take just a couple of seconds. There are about 11,000 kids expected to be newly diagnosed with cancer from 0 to 14 in the country. So 11,000 new diagnoses in 2020. 15 to 19, there's about 5,800 expected in 2020. So all in all, you've got less than 17,000 kids under 20 diagnosed this year, which is less than 1% of the total cancer diagnosis this year. So childhood cancer really is very rare compared to adult
And
cancer.
most children's hospitals as well that I've talked to across the country also, they usually are serving kids or adolescents up to even the age of 21 and 22.
Yeah, that's absolutely true. And that's why I said things differ, right? So a lot of major centers, based on whether they use advanced practice providers who have a license in their state to only care through 21 or whatever. But yes, where I work, we typically only care through around age 21.
Yeah.
Okay, that's good information to know. Back to the different types. So we've talked about leukemia and lymphomas, and then moving on to solid tumors, which is an area I do not know much about. So what kind of characteristics go with that?
Yeah, so solid tumors, like we've already said, leukemias, lymphomas, that's 28% and 8%. So we're already over a third of childhood cancers. And then the last category we get to isn't also a big chunk. So solid tumors is the remaining, and there's so many different types of solid tumors. It just means cancer that's out of control in a portion of the body that is not blood, lymphatic tissue, or our fourth category, which is brain and spinal cord, right? So if you think of cells in the body from bones, from muscles, from skin, anything like that, those would all be considered solid tumors. And then there's further breakdowns. There's soft tissue sarcomas, there's bone cancers, there's cancers of the eye and the liver and solid organs. And there's a lot of breakdown there, but these are very different based on diagnosis and presentation for sure.
Okay, and then you mentioned our fourth category, which is also tumors, but it's brain and spinal cord tumors.
Yeah, and so this is another very common one in childhood as opposed to adult cancers. Of course, there are adults with brain tumors as well, but much more common in the childhood cancer space. And so I think this is about 26% of childhood cancers. And so this is very common. And one thing that I would note when talking about brain and spinal cord tumors, when we're thinking about cancer, we're usually thinking about something called malignancy, right? Like cells that are actively growing very, very fast. In the brain and spinal cord tumors, these can be dangerous whether they're malignant or non-malignant, or benign is the other word for it. And so sometimes we will have kids diagnosed with a tumor that may be termed a benign brain tumor, but would still receive typical cancer therapy like chemotherapy and stuff because of the location of that tumor and the structures that it can affect in the brain and the spinal cord.
Right. Yeah, probably because they can't go in and remove it, right? Because of the sensitive areas that it might be in.
Exactly. Yeah. Surgery in that part of the body, obviously very difficult, very dangerous. And then even things like radiation therapy and stuff are very difficult to do when you're near those structures.
James, which category does neuroblastoma fit into?
Neuroblastoma would be one of those solid tumors. It's a fairly common one in childhood cancers when you're looking at solid tumors in particular. Again, I brushed up on all my stats before this. It's about 7% of childhood cancers are neuroblastomas.
Yeah, I know we've served a good number of those in our time at Lighthouse, and so I knew it was one it's obviously not the 25%, but I knew it was one of the more common ones.
Yeah, and neuroblastoma again can have a lot of different range of illness and factors, but a lot of times the families that you get to know when you're a cancer provider, a cancer nurse, are ones that can go through a pretty rough journey too. So neuroblastoma can really leave a mark on families and loved ones of those kids for sure.
That's great for that info. Thank you, James. Let's transition to the different ways that that children are diagnosed. What are some of the ways that the diagnoses happen?
Yeah, when we were thinking about how we would have this podcast, I was thinking, well, when I'm teaching a new family, that's kind of the next thing we get into. Make sure they understand what cancer is and what their child is facing with their particular diagnosis. And then we start talking about all these things that are happening in a flurry in the hospital, right? And so whether you're somebody listening because you have a family that's been touched by cancer, a loved one, or you're learning just how to support people who are, here's some things that I think would be important. And so, yeah, so things can be caught. Childhood cancer can be caught in so many different ways. Somebody could be visiting their primary doctor, right? Their pediatrician. The pediatrician could see something that is odd on exam. It can be caught on a blood test for sure, especially these liquid tumors that we're talking about, leukemia and lymphoma. Sometimes it's even caught by the family themselves. Leukemia is known for bone pain, and a lot of times this clinical picture of a child with a limp or with leg pain can really cue people into, let's look into leukemia or something like that. So lots of different things, always followed up by biopsy pretty much though, right? So once you are suspecting something like cancer, biopsy is going to be your golden test.
Yeah.
And explain what a biopsy is for, we've got this time together, we have a lot of big words that we're going to be spitting out. So if someone is not familiar with just what a biopsy is, can you give us some insight?
Yeah. So biopsy is just a big word, like you said, that means testing a piece of tissue from the body. And so it can be a liquid biopsy where you're testing blood. It can be a biopsy of a solid part of the body, skin, whatever. And the main thing that we break down for families is, well, what is that going to look like for you if your child's going for biopsy? So there's closed biopsies and open biopsies. Closed is generally just like a needle going in and pulling some fluid or tissue out. And open would be more like a surgery where the skin is opened up and a piece of tissue is removed.
Good to know. Excellent. Mm-hmm. So imaging, there's a lot of words with this, but we hear a lot about scanxiety from parents. So I know that we had a variety of things, even just being tested for leukemia. Can you go through some of the different scans and the x-rays and things like that and what they're looking for and how it's used?
Yeah, absolutely. So once you get that biopsy, maybe you have the result already or maybe you don't. The next thing is we want to know, well, where is this cancer located in the body, right? Is it localized? Is it in that one spot that we've seen it or suspected it, or has it spread, or how big is it, right? So all these different tests we'll mention are just ways to do that, right? So a lot of people have heard of a CAT scan or a CT scan. It's just a scan that sometimes kids are sedated for and sometimes they're not. It does require the patient to lie pretty still. And so it's just a special like x-ray or image of the body that shows different slices of the body at different levels. So CAT scans can also involve contrast or not. And so they could get special medicine put into their veins or they could drink it and it lights up different parts of that scan.
I want to talk about the staging and the grading because I remember, having leukemia, you always ask like what stage cancer you have, and we didn't have a stage. So I don't think people understand that. So how are cancers staged and why is leukemia not?
Yeah, so staging is typically, you're exactly right. It's for solid tumors or lymphomas, so things that are not leukemia. And I think the reason for that is stage is mostly about how far spread this disease is. And with a cancer like leukemia that's in the blood forming part of the body starts in the bone marrow and spreads throughout the blood very quickly, you kind of have systemic disease very quickly with a leukemia most of the time. So staging, stage 1, 2, 3, and 4 typically, but some cancers have different numbers than that as well, but those are the most common. Has to do with, is this tumor very localized in one spot? Is it in one spot with a little bit of local spread around there to a few lymph nodes or to a few adjoining tissues? Or is it far spread, which is typically like a stage 4 or what we would call metastatic? The cancer has left its original origin or spot where it begins and it's spread to a different part of the body. So yeah, everything other than leukemias typically has a stage to it. And grading, it gets a little bit more scientific, but it has to do with how likely that cancer is to grow at a fast rate, whereas a lower grade tumor is less likely to grow quickly and grow in size and become a problem very quickly, and a high grade 3 or grade 4 is more likely to grow very quickly.
That's great info. Hey, James, talk about this term. We've all heard it, or I think a lot of us have heard it in just the medical field, spinal tap. What's a spinal tap? What goes into that?
Yeah, sometimes people think it's something very, very scary when you call it spinal tap. And so we will say that term, but we'll kind of quickly actually teach parents another term for it called a lumbar puncture. But they're one and the same. And so a spinal tap or a lumbar puncture is where a needle is placed into a patient's back in between their vertebrae, in between a couple of vertebrae there, with the goal of hitting the space around the spinal cord. If you hit that space, there's a fluid that bathes kind of that area called the cerebrospinal fluid, or just the spinal fluid. And a lumbar puncture can be for a couple of things. It can be just to test that fluid to see if there are cancer cells in that fluid, or it can be for that and for delivering medicine to kill cancer to the spinal fluid, right? And so the main two groups of childhood cancers who need lumbar puncture or spinal tap are leukemias and brain tumor, spinal cord tumors. Leukemias being a cancer of the blood, there's a blood-brain barrier where the cancer can easily jump in leukemia from the blood to the spinal fluid. And so we need to test that to see if there's any leukemia cells in it. And often you will automatically put chemotherapy in there as well, just to kill any that could be hiding. And then a brain tumor patient or a spinal cord tumor patient can also just have a lumbar puncture to test for cancer cells there.
Gotcha.
And you sedate children for this, right? I know that because it can be incredibly painful.
Yeah, again, I think that can vary by hospital, by site. Where I work, we sedate almost across the board, but there are certain kids whose body size may cause that not to be the best course, and so they might do it with conscious sedation where they're just kind of sleeping all the way out of it, and some people will do it wide awake as well, so it varies.
So another way, and kind of one of the main ways kids are diagnosed, is often by simple blood tests. And there's a bunch of different kinds of blood tests, and then they're often given them a lot throughout treatment. So what are the most common? What are they looking for?
Yeah, great question. I'm going to use your blood test question to kind of do a caveat as well. When we're talking about biopsy, I wanted to mention one particular type of biopsy called a bone marrow biopsy, and it's closely related to blood tests too. So bone marrow biopsies are closed biopsies, like what we talked about before, where a needle is inserted into a bone, typically like a hip bone, but not always, but typically the hip bone, to pull out some blood-forming cells in the bone marrow. And so it can be a bone marrow aspiration or a bone marrow biopsy, and that's used to diagnose, to see if cancer has either spread to the bone marrow. Some cancers can spread there, or if it initiated, it started there. The blood tests, other blood tests, kind of the big one that we teach families about and patients about is a CBC, which stands for a complete blood count. And the quick and easy breakdown of this is when you go and have your blood checked and they're looking at the types of cells in your blood, so not electrolytes, not iron or anything necessarily, but literally the cells in your blood. That's a complete blood count, looking at red blood cells, white blood cells, and platelets. And there are more breakdowns beyond that. But we use the CBC a lot in oncology care because we want to know, are your counts kind of out of whack, either from your disease like leukemia or lymphoma, or because we've been giving you treatment, has it lowered some of those counts? And every aspect of that really can change whether you get your next dose of chemo or radiation, how likely you are to be at risk for infection, a lot of different things. So we take a lot from CBCs. The other blood tests, can matter depending on tumor type. They can draw tumor markers sometimes in the blood. They can check chemistry, so your sodium level, your liver function, your kidney function, things like that.
Yeah, for leukemia families, blood count is everything. I mean, that's what you go for. You wait till those counts come in. It determines the next, couple of weeks of your life, and that's everything.
Yeah.
Getting that CBC. So let's talk about ports, James, because I thought the port was the greatest invention ever for our family. It helped Carter a lot. But there's sometimes people don't know that they're going to be able to see them, and there's different kinds. So tell us about the kind of two main kinds and what they're actually used for.
Yeah. So port is a term that you would hear a lot, but even kind of a bigger umbrella term would be a central line, right? So in childhood cancer, most kids are going to get some sort of central line, and all that means is it's kind of an intravenous line or an IV that is either placed right into a large blood vessel near the center of the body, or it's placed somewhere else and the tip of the catheter or the tube that comes out of it ends in the center of the body. And so that's the big umbrella term of central line. And then those break up into internal central lines or external, or sometimes you'll hear CVL, which just means central venous line, right? And so an internal would be like a port, like what you're talking about. A lot of people in childhood cancer are very familiar with ports. We love to put in ports because they are internal. There's nothing hanging outside of the body when they're not being used. It's placed under the skin, a lot of times in the upper chest, sometimes in the flank, and even occasionally like in an arm or something. But it's just a little semi-permanent IV that is placed in those areas and is accessed by a needle. And so it gives us access to those large blood vessels in the middle of the body. We can deliver chemotherapy, medicines, blood products right into those areas, and it lessens the risk of the IV being lost or medicine spilling out, and it also just gives us really easy access to blood to draw for different tests and things like that. We find that kids, it's a big learning curve when they've never used them before, but we have great child life specialists where I work that can make the process of accessing ports as good as it can be, and kids get really, really strong and resilient with it. With the external, central venous lines, some kids do need to get these, and it's a type of IV or tubing that does have a portion that hangs outside of the skin at all times. So these families have to learn a lot about these lines, how to keep them clean, how to change the dressing over them, just a lot that goes into that. But they usually have 2 or 3 different ports that we can use at any one time.
James, you talked about it a little bit because this is obviously through a port is one of the main delivery systems of treatment. So you talked about chemotherapy. Talk a little bit more about, for folks out there that may not understand, what is involved in treatment. And even for those that may hear the word chemotherapy but never really know what that actually means. Talk about what are the different types of treatment for kids.
Sure. So chemotherapy, a lot of people they think they're familiar with this term. It sounds very scary. And honestly, even in the oncology space, I think we throw it around a little bit more than we should, calling some things chemotherapy that truly aren't chemotherapy. But when you hear the term chemotherapy, we're often meaning any medicine given to destroy cancer. So really what we should be using is a bigger term, anti-cancer drugs or something. But chemotherapy technically is medicine to kill cancer that's made from chemicals that's not an immunotherapy. And we'll talk about immunotherapy. In fact, why don't I just explain what immunotherapy is? Immunotherapy would be those anti-cancer drugs that aren't standard chemotherapy. Standard chemotherapy, the way I explain it to families, is like a medicine that goes into the body. It's not targeting necessarily just the cancer cells. It is more of a looking for any cells that grow quickly in the body and destroy, or going after them, killing them. And so a lot of the side effects from chemotherapy that people experience is because we have some cells in our body that just naturally grow faster than others, right? Our hair cells, our skin cells, the cells inside our mouth and all the way along the GI tract. And so all these cells grow more quickly compared to other cells in our body. And so when chemo goes in, chemo's looking for anything growing quickly, and it's going to harm any of those things, which means it kills the cancer cells very well, usually, but it has a lot of collateral damage. Immunotherapy is different. It's anti-cancer medicines, but they're usually more targeted, and they're aimed at telling your immune system to go after the cancer itself. It's like either turning on your body's immune system to go after it, or using some antibodies or things that have been made in a lab that automatically go in and use your immune system's natural function to do those things. And I should say, chemotherapy and immunotherapy can be IV, which is what people usually think they are, but they can be oral too. They can be pills and medicines taken, liquids taken. They can be injections into the muscle. They can even be like intrathecal, like put into the spinal fluid. So
the immunotherapy, is that kind of a new trend? Is that where cancer treatment is headed?
Yeah, it's newer. You know, we've been doing types of immunotherapy for a long time, and I would say there's still more immunotherapy in adult cancers than there are in childhood cancer, but there's definitely more and more happening in childhood cancer with immunotherapy and cellular therapy. If people have ever heard of CAR T cells, that's a cellular therapy that's closely related to immunotherapy. There are some monoclonal antibodies being used in childhood cancer now. So yeah, it's definitely moving that way.
So outside of the chemotherapy, then there's radiation, right? And so talk a little bit real quick about what is radiation. What's that look like for a kid?
Yeah, so radiation, whereas we said chemotherapy and immunotherapy are usually affecting the whole body, or they're systemic, they're taken in by ingestion or through the IV or whatever, a lot of the body cells are exposed to them. Radiation is typically more of a localized treatment. So it's going after the main tumor site or maybe a few main sites of spread. And so what's different is that side effects from chemotherapy and immunotherapy are often can be side effects all over the body and all different types of portions of the body, nausea, vomiting, hair loss, these kind of things. Radiation typically causes side effects just in the spot where that radiation beam hits the body. So it's a high-level energy beam is what radiation is in general. There's, again, breakdown with many different types, proton beam, all these things, but it's a high-energy beam that's, again, going to destroy cells that are more active, that are more actively growing. And so if it's aimed at a part of the body with a tumor, it's going to damage the DNA and those tumor cells, hopefully a lot more than the cells around it, because they're more active and they're splitting and they're growing. And so when it damages them, hopefully it causes them to die and shrinks that tumor.
Yeah. And then there's also surgery, right?
Yeah, and so surgical treatment can be less frequent, I would guess, but not necessarily. Usually surgery, especially for solid tumors, is a big part of the treatment. It's just not often the only treatment. In some adult cancers, localized prostate cancer, skin cancers, things like this, surgery could be the only treatment. And there are certainly some childhood cancers where surgery is the only treatment too, but often surgery is a part of the treatment for a childhood cancer. Maybe surgery is done first to remove the majority of the tumor, or hopefully all of it, and then some additional chemo or immunotherapy or radiation is given afterwards to make sure it's all gone. And then there can be some surgeries that are done after the fact. Maybe the child needs to get a systemic therapy like chemo or radiation first, and then the tumor has shrunk enough for surgery. So it all depends.
I think it really is an unknown for folks, and I think they've you hear the term, but you don't really know what goes into it, and as well as the length of time that goes into it, and that's bone marrow transplants. Can you talk for a few minutes about what is a bone marrow transplant, and then who needs typically a bone marrow transplant?
Yeah, this is a really good question. You're hearing more and more about bone marrow transplant, and I think it's a good thing because hopefully more people are choosing to sign up for things like the bone marrow registry, the National Bone Marrow Registry. But so let's talk about that. So bone marrow transplant is the term that we use a lot in the lay world, but we can also use the term stem cell transplant. They're mostly interchangeable. What it means is there are certain types of cancer that need really high doses of cancer treatment like chemotherapy and or radiation, and they need those high doses to completely wipe out, or hopefully completely wipe out, the cancer in the patient's body. And so because they need those really high doses all together at once, we talked about how chemotherapy and immunotherapy and those things can cause a lot of collateral damage to the body. When you get those high doses of chemo that are needed to kill these cancers, it often completely wipes out the bone marrow. And we talked a little bit about it, but the bone marrow is your factory in your body that makes all your blood cells. And so when you get these really high doses of chemo, hopefully it's really doing a huge number on killing that cancer, but it's going to do a big number on that factory, and your blood cells are going to drop to next to nothing, red, white platelets. And so a stem cell transplant or a bone marrow transplant is when that patient gets that high dose of chemo, and then they get what we call a rescue, or a stem cell rescue, where they get bone marrow stem cells, which are these immature young cells. It's kind of like they're still growing up. They haven't gone to college yet. They haven't decided what they're going to be yet. They could be a red blood cell, a white blood cell, a platelet. So they're stem cells that have the whole world ahead of them. They could become whatever they want, but if you give them to a patient as a rescue, it can go in and hopefully become part of their blood forming system, become a new factory for them. You took their factory away, and now you're giving them another one, and it helps them recover from those really high doses of chemo. And that can actually be done. They can donate stem cells to themselves, which people don't always realize. Somebody can have stem cells removed before those high doses of chemo, get the high doses of chemo, and then get their own stem cells given back to them. Or it can be from a donor, which is, I think, what we're more familiar with. And that's where somebody else would donate the stem cells, they get the high doses of chemo, and this patient gets that donor's stem cells put into their body, either a relative or a parent or someone through the registry. And so you said who gets it? It can be patients with leukemia and lymphoma, but it can also be patients with solid tumors, because solid tumors very often need these really high doses of chemo and stem cell rescue. So typically, at least at our center, these patients are in the hospital for around a month, if not more. They get something called a bone marrow or stem cell prep, which is those high doses of chemo that is attacking their cancer cells. And then that's typically maybe a week or so before their transplant day. Then they get their transplant or their stem cells infused into their body, stay for several weeks after to make sure, one, we need to see if the factory is taking hold. Are they getting what we call engraftment? Are they getting these stem cells to start to work for them and to make new blood cells for them? And we also have to watch for, or the option would be, opposite would be watching for rejection of that stem cell transplant. Maybe the body knows that's not their stem cells and is not accepting it. And then there's also just watching for the side effects of those high doses of chemo. So at least a month typically, Chris, if not more.
And that's what we've heard from families, and I don't think everybody always realizes what goes into that it is a lengthy process. When you hear bone marrow transplant, so stem cell transplant, that means that family's in there for 30, maybe longer days, and that's their home. And so it's just an added weight on a family. Thanks for explaining that, because I don't think everybody fully understands what goes into that.
And James, you mentioned the registry. Can we talk about that for a little bit? Because that is a way that people can really help, and I don't think people understand what it is or who is allowed to be involved in it, which is a lot different than people probably think. Tell us about the registry.
Yes, absolutely. I love this that you brought this up. So National Bone Marrow Registry is like we said, a lot of different patients could need a life-saving treatment with a bone marrow transplant or a stem cell transplant. Cancer is a big cause for this need, but there's also other diseases, blood diseases, like sickle cell anemia or immune dysregulation things. There's a lot of different things where people need to have these high doses of chemo and stem cell rescue. And so when you sign up for the National Bone Marrow Registry, you're saying, look at my DNA or look at my bone marrow type and see if there's anyone in the country who may need my type of bone marrow. And we all have all these different markers on our stem cells on our bone marrow type called HLA. And so some patients need to receive a type that is the most similar to their type. And so that's why often a sibling will donate bone marrow, but a lot of people don't have a sibling who is their type. You only have a certain percent chance in having a sibling that has the same type as you. And so when someone doesn't have a close living relative with that type, then we look in the National Bone Marrow Registry. And I'm super blessed to work with great colleagues who are nurses, who are BMT coordinators, and they look for donors and things like this. But when you sign up, it can be as simple as just doing a swab on the inside of your cheek and then sending it back in. You can do this by mail. Go to Be the Match. I think it's bethematch.org, and you can have them mail you a kit. My wife did this probably a year or so ago, and we took pictures, and she's a hero for doing it. She hasn't been called yet, but you're not saying, yes, take my bone marrow. When you do it, you're just saying, look at my type and notify me if someone might need my bone marrow type. I think there's occasionally blood drives too, that they can just take one extra little tube of blood and just put you on the registry through that as well. So
that's great. Thanks for even naming the site. We'll also put a link to that for those of you listening in the show notes, just so you can click to that, because if you're curious and want to learn more, that's where you start.
James, there's so much information, and parents, when they're first diagnosed, they just get so much all at once. And so I think this will be really helpful, not only for families who maybe have just been diagnosed, but friends and their communities if they want to kind of understand what some of the terminology is. So I appreciate as always that you lend us your nerd glasses, as you said, and give us the facts and figures. We're going to put in our show notes a bunch of resources that families can use, anyone can use if they want to read up more and learn more about any of the things we talked about today. But thanks for just always being generous with your time and for giving your life to this cause and doing this. I think that oncology nurses are the biggest heroes that there are in the whole world, and I mean that. So we're going to hear more from James later on. He's going to get into his personal story, which makes you love him even more. So we're looking forward to that. But thanks so much. And for all of our listeners, thanks for coming in today and just sitting with us with James. And we'll see you later till the next episode of the Lighthouse Podcast.